Good afternoon for those of you on the East Coast, and good morning for those of you on the left coast. My name is Dr. Christopher Bromley, and I'm here today to talk about laser clinical applications in podiatry 2021. We're going to go through some disclosures. For those of you who know me, I do quite a bit of teaching and around podiatry and orthopedics. Today's lecture is underwritten as an educational grant, and I also do some consulting for other laser companies. I don't own any interest in them, and this is again an educational CME presentation. Background. I am a practicing podiatrist. It's hard to believe it's been 30 years already. I co-own a 5-physician group that's part of a 70-physician multi-specialty group. I am the chief of foot and ankle surgery at Vassar Hospital, and my particular practice specializes in sports medicine, all aspects of foot and ankle surgery, as well as complementary medicine, regenerative medicine. I have been using lasers in my practice for 18 years. I was introduced to laser by a really great friend and mentor who taught me everything I needed to know after medical school about regenerative approach to healing. I was seeing a patient. She called me and asked if she could laser the patient. I asked her what it was. She, laughed and said, "Do you trust me?" I said, "Yes." I said, "Is it going to hurt?" She said, "No." And a week later, the patient was in, no bruising, no swelling. And I called her up and said, "What is it?" And she said, "Well, you need to come and see me." So I did. And I've worked with half a dozen laser companies in the last 18 years. I've done clinical trials, studies, been part of FDA approval. And I'm here today to talk about how you can incorporate laser into your practice. And if you have laser in your practice, how you can expand it. So objectives for today's talk is to understand the basic evidence to support the mode of action of laser therapy. Next, understand how lasers affect cells and tissue, thus the conditions that we can use lasers to treat. And then go through those conditions and understand how to use the laser in your treatment protocol. First off, what is a laser? So a laser is an acronym. It stands for Light Amplification Stimulated Emission Radiation. Laser light can be monochromatic. It can be a single color or wavelength of light source. It can be collimated. It's a state of being parallel or directional. And it can be coherent, which is a property identical to phase and time relationship. The quote on the bottom, the treatment with laser light is not based on heat development, but based on the photochemical or photobiologic effects on cells and tissue. A term that we use a lot is photobiostimulation. We're using the energy and the light source to influence healing in tissues within the body. So this is what a spectrum of visible and invisible light looks like. You have radio waves to the right, X-rays to the left, and we have the visual spectrum of light right in the center. There are two main factors, benefits to light therapy based on the wavelength of the light and the intensity. So the wavelength we'll talk about in reference to where it falls on the spectrum, and then you can adjust the intensity, which can affect the depth of your treatment. So this is that visual spectrum. We just talked about ultraviolet, and there's visible, near infrared, mid-infrared, and far infrared. The typical wavelengths that we use in the use of laser treatment in the practice is somewhere between 400 and 900 nanometers. So that usually for most of the lasers I've used have been in that 600 to 900 range. The 400 or lower blue spectrum we use in some of the lasers that we do for the treatment of onychomycosis. But the sweet spot is somewhere between 630 and 900 nanometers. And that will explain as to what that means and how that influences tissue. So there are a number of different lasers. So lasers are classed based on their power. So any laser that is considered a low power laser will be lasers that are class 3 or below. So you'll hear terms like low level laser or cold lasers used intermittently. Those are typical lasers in a class 2 or 2B. When you're using them, they do have a photobiostimulation effect, but there's no heat that's created because of the strength of the laser. These are low-powered lasers. They work, but they will take more treatments and longer treatments to have the same cellular effect. Some of the newer lasers that we have in our practice are the higher powered lasers. These are class 4 lasers. They're considered medical lasers. They are going to have more range in reference to adjusting power and how we measure the power in joules, and we can get deeper penetration with the higher power lasers, and we can have a much stronger effect on the deeper structures. Like if you have a patient with osteoarthritis, we'll get into that. Those deeper tissues, you'll have more bang for the buck with a higher power class 4 lasers. Names that we use a lot: biostimulation laser, therapeutic laser, bioregulating laser, and photobiomodulation therapy. There's also something called light therapy, where you're using a laser, a diode of light, and you'll see things on the internet. Those are not typically lasers. The lasers are medical grade. Those are purchased by physicians. You can't buy them on the internet. All right, so what can we do with a laser? So in your practice, you would use a laser to treat any of the following conditions. So if you have a patient who comes in today and they're in with an ankle sprain, the typical podiatry approach to an ankle sprain would be, okay, we're gonna, if it's new, current just happened, we're gonna rest, compression, elevation, rest, we're gonna stay off it. Well, instead of prescribing an anti-inflammatory to reduce the pain and swelling, you would add laser as first line to treat that patient right away. So example would be, you come in with an ankle sprain, we take an x-ray to make sure there's no fracture, maybe we did an ultrasound to take a look at the ligament structure, and I would say to you, you have 3 treatments: ignoring it, hoping it's going to go away; treating it conservatively; or surgery. We'd like to avoid surgery. We agree, yes. You'd say, so okay, great. I'm going to do some laser treatment today to help reduce the swelling, to help increase blood flow in the area, and start the healing cascade right away. These are patients that respond great to laser. I'll say we're going to do maybe some K-taping. Maybe we'll order you a brace, but then you'll be coming in weekly or bi-weekly for laser treatments as part of your rehab. So I think about laser as the first line of treatment for all the conditions you see, as the tool in my toolbox that I'm going to use to help fight off inflammation and reduce pain. You have other conditions, obviously all the things that we do in podiatry. I used to say you can do everything in podiatry except for fungal nails. Well, I can't say that anymore because obviously we have fungal nail infections. One of the things that most people don't think about lasers for is the use of lasers for wounds. Obviously, wounds there's a neuropathic component, there's a vascular component, there's infection, there's bioburden. Using lasers, if you have a wound practice, is an awesome tool. I mean, think about it. What can we do for the patients in podiatry that have, poor vascular supply? They have small vessel disease, they have autonomic neuropathy, they have sensory neuropathy. Well, a laser is a great tool to supplement all the other things that you do so well. Not a substitute for good debridement, offloading, and the proper dressing, but really a great tool to help speed up that healing. We use fungal lasers in this practice. I've tried all the different fungal lasers on the market, and I've done clinical trials for different types of lasers. Fungal nail treatment with lasers we'll get into in this discussion. Again, a very valuable tool. What are the other things that we have? We've got topicals, which aren't really going to do much. We have orals that are available, but they have a lot of side effects. So most patients are very open to talking about the use of a laser for fungal nails and also warts. I still use quite a bit of compounding as treatment for warts, but I do and have incorporated the use of class 4 laser for the treatment. So again, all the things under pain and inflammation, that you see in the foot really can respond well to laser, the injury patients, and then the other dermatologic stuff that we treat. Here's what an advanced, this is a class 4 laser. This particular type of laser has a couple of different hand pieces. There's the one main probe that we will use for the musculoskeletal and pretty much everything we do. And then there's a smaller probe that we use for the fungal nails and for the warts, but these are all pre-programmed. You don't have to be, a science genius or laser expert. The companies that sell these have them pre-programmed for you with training, and then there's lots of information that we have as handouts to our patients so that they can understand what it is that we're going to do. How do lasers work? So here's an example of what happens. Whenever you use a laser, particularly a more powerful class 4 laser, there's going to be increased blood flow. So the image on the left here, you can see this cooler blue, purple. After the treatment with a laser, you'll see the increased blood flow after just one treatment. What's happening with the way that tissue responds, there'll be the laser will cause the red and infrared triggers the release of nitric oxide, which increases vasodilation. Again, everything that we're doing in our practices, with the exception of an active trauma or hematoma, we want to increase blood flow. Blood flow is the thing that we need the most to stimulate healing, form collagen, and get things to repair. So again, it's all about the cellular response, the release of nitric oxide, which again results in vasodilation, and then also stimulating things like VEGF and collagen formation. So what are the cellular responses to laser? So when you use a laser, there's an intracellular response, and that intracellular response is based on a photochemical reaction that is initiated when any tissue is exposed to a laser. The cytochrome C oxidase receptors within the cell membrane of the mitochondria absorb the photon energy, which causes the release of ATP, and thus ATP, being the fuel that drives the cell, initiates photobiostimulation. So remember the term photobiostimulation. Again, it's causing ATP secretion. And this increased metabolic rate helps speed up the repair process in any tissue that's diseased or damaged. The benefits of laser to your practice. Well, pretty simple. A laser is one of the things that you can use in your practice to improve your outcomes, which is really important. It can improve your patient experience. It can expand your protocol. When you prescribed cortisone injection or an NSAID, those are older treatment methods. Laser is far superior. It doesn't have any side effects. It's easy. It's safe, it's non-toxic, it's non-invasive. There are no side effects. You have patients who have difficulty tolerating NSAIDs because of hypertension or because of the GI complications. So this is an excellent tool, and all of the patients in your practice could benefit from. You're going to plug laser in where you would have thought about using an NSAID or a cortisone injection or a pain medication. I use lasers in addition to the things that we talked about on the list before for painful diabetic neuropathy. I have lots of diabetics with neuropathy. I'll be using some B complex supplementation, but I'll also be using the laser to stimulate that blood flow, which will help with the repair of their nerve structure. So what are the general effects of laser? So what we see when you look at, these are not just my opinions, we'll go through some studies. We see increased cell growth. Laser photons accelerate cellular reproduction and growth. Increased metabolic activity, as we mentioned earlier. The photons will higher output of specific enzyme, greater oxygen food particle loads within the blood cells. Therefore, there's greater production of basic food sources and the ATP that we talked about. Faster wound healing. Again, what is the problem with wounds? They get stuck in the inflammatory phase. There's not good blood flow. It's stalled. Laser photons can stimulate fibroblast development and accelerate collagen synthesis in damaged tissues. As we mentioned earlier, there's increased vascular activity. Laser photons increase vasodilation because of the release of nitric oxide, which then causes increased healing. And again, we can set the laser to work with pain reduction. I use lasers as part of my pre-op and post-op protocol. The post-op protocol, we've been able to use lasers twice a day to speed up the post-op healing, reduce the need for post-op medication, and it's really helped me improve my outcomes. So here's a great image. The top of the image here, you'll see the laser photon coming in. They're reacting with the cell structures. You got a release of nitric oxide, the stimulation of the reactive oxygen pathway, ATP secretion, and you see cell transcription. This process causes growth factor production, cell proliferation, cell mobility, extracellular matrix deposition, and again, this feeds into wound healing, tissue repair, tissue death prevention, reduce of inflammation, reduce pain, edema, helps speed up the healing of acute and chronic diseases, and it can be used for neuropathic pain as an alternative to a drug. As I mentioned earlier, you can use lasers to stimulate healing of your wound patients. It can speed up that inflammatory phase. You know, a lot of these diabetics, because of their autonomic and sensory neuropathy, get stuck in the inflammatory phase, and we can use this to speed up their healing. The angiogenesis, again, is very important for these. It has to do with the stimulation and migration of VEGF. We also see enhanced macrophage, fibroblast, and lymphocyte activities, which are all part of the healing. Again, the cellular production, again, the release of ATP, production of fibroblasts, which will help in this wound healing patients for collagen production. And one of the things that we think about with wound patients is whether or not it's healed. Is it healed or just in remission, and whether it will break down again? Well, the quality of the healing is based on the collagen production, not just getting something to epithelialize over. So lasers can help you reduce the remission of these wound patients. Again, increase protein synthesis by stimulating DNA production with the ATP, and again, regulates cell membrane potential, increase exchange of potassium, chloride, and sodium. So one of the things that I get asked all the time is, how do you use a laser for pain? So neurotransmission is facilitated by laser stimulating the elevated levels of serotonin and acetylcholine in the area that's treated. You also have an increased release of cytokines such as prostaglandin 2, which can lower the levels of pain and inflammation as a mediator. So again, the way if you have a patient who has, let's say, chronic regional pain, or what we used to call RSDS, you know, the old treatment was, you know, we just have to kind of wait it out, give you some physical therapy. You can use a laser in a patient who has this condition, or if you have a patient with painful neuropathy, or as I mentioned earlier, I use laser as part of my post-op protocol so that we can reduce the reliance on pain medication. I don't use any NSAIDs around any of the surgery patients, and I very rarely will use NSAIDs even in my sports practice, because I'm looking to reduce inflammation without reducing the patient's ability to heal. Again, when we're talking about inflammation, there is a release of beta endorphins with lasers. There is a study that we'll get into that showed chemical change in patients. You know, one control group was ice, the other group was laser. There's a reduced release of histamines, bradykinin, and substance P. There's also decreased C fiber activity by blocking depolarization. You can stimulate neurotransmitters at the synapse with lasers. You can, as we said earlier, you're increasing nitric oxide and increasing nerve cell action potential. So let's talk about some studies. This is a study that was published in Foot and Ankle. This is the use of low-level laser therapy for chronic plantar fasciitis. Now, obviously, plantar fasciitis is the most common thing that we see in a practice, and we know that the disease process in plantar fascia is the breakdown of the plantar fascia. It's really not an itis, it's a plantar fasciosis. When you look at ultrasound, you'll see that the plantar fascia is either torn or blown out within the fascia with a hypoechoic area. That's an area that has very poor blood flow. Plantar fascias typically heal very slowly. So instead of giving somebody a cortisone injection, which if you put the cortisone and the local into the plantar fascia will cause it to tear more, if you put the cortisone injection with local above or below the injury, that may help the patient's perception of pain, but the cortisone will actually slow down the healing response and suppress that. So instead of doing a cortisone injection, and instead of using an NSAID, use all the things that you normally do. Use the taping, make orthotics, do the stretching, but use the laser to help reduce the inflammation and the pain, and use the laser to stimulate blood flow and to stimulate collagen. So in this particular study, the patient received 2 treatments a week for 3 weeks, so a total of 6 treatments. The pain scores on these patients went from 67.8 out of a scale of 0 to 100 after down to 6.9. And they had a very good long-term follow-up in the sense that it would, again, you get the plantar fascia to heal, but a much better quality heal than you would if you did the traditional NSAID or, God forbid, a cortisone injection. So this is showing you 2 treatments a week for 3 weeks. So that's a total of 6 treatments. And then they track these patients out 6 months and 12 months later. So they saw that not only did the patients do well, but they did well long term, and they had a much lower rate of recurrence than you see in a patient that would have been treated with a typical standard of care NSAID and possibly cortisone injection. This is an interesting study. So this one, it talks about ultrasound changes in a laser group. I will tell you that in my office, we use quite a bit of ultrasound. And when you do ultrasound of a plantar fascia and you see a big black hypoechoic area or tear in the fascia, if you ultrasound before the laser, do, let's say, a class 4 laser for just a few moments until you get a response, and you ultrasound it after, you'll be amazed. I've got really great before and after pictures of what the ultrasound looks like when you've done a laser to this patient. So this particular, this was published in 2010. It was showing ultrasonic evidence of the plantar fascia after laser treatment. This is a double-blind, randomized, placebo-controlled study. So they were this particular study was done with a lower-powered laser, a class 2, and they did participation patient 6-week follow-up. But they did see in this particular group of patients that the patients who had the laser did significantly better over the patients who had the placebo. And again, that's what you'll see in your patient group. Another study that was published in 2013 looking at the effect of laser for treatment of plantar fasciitis. This particular study was, again, a double-blinded study, 50 patients that were treated with laser and placebo, and they had 10 treatments, and the results show that the laser was significantly better at reducing pain in the plantar fascia compared to the placebo. Again, so not just my opinion, there is a number of studies out there that show the effectiveness and safety of the laser. All right, so let's go through another study. This is, I included this study because it was about neck pain. I have pretty bad neck pain, but this was published in Lancet, which is obviously a very reputable journal. They looked at 16 random controlled trials, 820 patients, and they found that the patients had pain relief immediately after treatment and up to 22 weeks after completion. Now, for those of you like myself who've had neck pain is unremitting. When it's bad, it's like going to make you nauseous. So again, this is a study showing you that deep type of pain, osteoarthritic neuropathic pain in the neck. Another study, this one I included just because this is about tennis elbow, but tennis elbow is very much the same disease process as the plantar fasciitis. I included this because it was 13 random clinical trials, 730 patients that met the analysis, and patients were dosed directly on the lateral elbow, and they saw short-term relief and less disability than without, and they were able to continue with their regime. So again, very similar to the HEAL. This is another study. It's a systemic review of laser therapy for chronic joint disease. So these are patients that have chronic bone type pain. This was published in 2003. They looked at 11 trials, 565 patients were found to be acceptable. The laser therapy dose range significantly reduced pain and improved health status. So again, if you've got a patient who comes in who has sort of that chronic ankle osteoarthritis or first MTP arthritis, you can use this as an alternative to a drug or a shot. You can have that benefits, particularly if you're using the higher powered, class 4 lasers. You can really get good bone penetration, get reduce of that inflammation, give them some pain relief. Again, no substitute to what we do really well in our practices, which is talking to the patients about, diet, weight loss, taping, orthotics, better shoes. This is just the laser is your tool, your go-to first line tool to offer the patients that opportunity to get relief and to get better faster. This is an interesting study. This does phototherapy enhance skeletal muscle contractile function and post-exercise recovery. The reason I included this study is because it was published in 2013. So the interesting thing about this study is that they looked at, there's 12 centers. They looked at the data set, and what they found is, so the control group was ice. The laser group consistently reduced the post-pain plasma levels of creatinine kinase and C-reactive protein. So the ice patients got relief, but the laser patients got relief. But when you did a blood draw, you saw a reduced level of creatinine kinase and C-reactive protein. So for me, that was important. I mean, for many years I was using laser. These studies weren't available, but to show you that there is a systemic change. Again, it was just one part of the body that was being treated post-exercise. But in this particular study, they show you the change in the levels of the inflammatory markers. Let me go back here a little bit. All right, there we go. All right, so continuous wave or modulated or pulse. So the power output, which is measured in watts, is constant over time. The average power is about the same level or lower than peak, and it can be, you can chop it up, you can modulate it, you can turn it off, you can pulse it. The treatments use continuous wave, which can also be pulse. So the continuous wave treatment is what we use most of the time in podiatry. So for pain, inflammation, arthritis, neuropathy, ulcers, wounds, if you're doing work, those are continuous wave. When we use a pulsed wave is for fungal nails, and if we're using it for warts as an ablation. The reason we use pulse is that when you use the higher power class 4 lasers, there's some heat created, and you're pulsing the treatment so that it doesn't overheat, patient get uncomfortable. So this is showing you what that looks like. So the laser part of this is going to show you how that works. Let's see if I can get this back up here. The laser mode operates. So you'll see the continuous wave here, modulated wave, pulse wave. Again, the typical thing in my practice is just to use continuous wave unless I'm doing fungal nails to get the most bang for the buck. Average dose. So when you think about tissue, you think about the number of joules based on the centimeter. So in this case, you've got an extremity tendon, 10 joules, ligament 10 joules, fascia 10. When we're using bone or muscle, again, we'll go down to 7. This is the total amount that we want to give over a centimeter area. So we're going to go over how to do that specifically. There's a couple of different ways to use a laser. Now, when you have a laser handpiece, you can think about distributing laser over the surface. My particular technique is to do a sweeping technique, more like the center, where I'm kind of waving back and forth. I stay a little bit off the foot, maybe a centimeter or so. There are lots of different types of grids, but again, you're watching the amount of joules you're adding based on the wavelength and time, and we'll get into that as we go forward. Couple of different types of treatment. A shallow treatment would be where you're off the skin, maybe a centimeter or two. Second treatment would be medium technique where you're basically the diode is against the skin, but you're not pushing. And then if you want to get deep into the deeper tissues, then you may push into the foot a little bit. For most of the foot applications, for a wound, I would use a shallow application. For a plantar fascia, I tend to use a medium up against the skin. And make sure I watch my timer here so I don't get in trouble. All right, so here's an example of what a typical laser looks like. We have one very similar to this in our practice. This shows you, you attach the handpiece here. You can have everything pre-programmed into the device, so it's very easy. In a lot of states, you can train your MA or your nurse to do the treatment because these treatments are attended. It depends on the billing. In some states, you've got billing codes, which we'll get into. In other states, you don't, and it's just a cash model. I tend to prefer the cash model. But again, there are uses of lasers for all different things. So use of lasers for onychomycosis has been our go-to method for the last 2.5 years. There have been really good results in reference to onychomycosis. The studies show anywhere between 86 and 90% relief. If you're going to be using lasers for onychomycosis, a couple of pearls. One is you have to treat the shoes. Two is you also want to be doing debridement before the laser so you get good penetration and make sure that the patients are treating any concurrent fungal conditions on the skin. Typical, what you'll see when you do a laser is before you take a picture. After the laser, you'll see, even after the first treatment, the nail will get very crumbly and almost like fall off if you touch it or debride it. What I do with my patients is I have them get an ultraviolet shoe sterilizer, drying, and I have them treat their shoes because all of their shoes have fungal spore in the contamination. I learned that from my good friend Carrie Zhang. In addition to the laser, I have them use a topical. I'm a big holistic fan of tea tree oil. If you want to use a paint-on lacquer, that's up to you. In the summer months here, we use the nail polishes that have the antifungal elements in them. And again, remembering when you do laser treatment is to tell patients it's going to take a year to grow out. If you have a bruise in your toenail, that subungual hematoma will take 8 to 12 months to grow out. The same thing is true with your laser treatment. Again, remembering to tell the patients that they have to do treating the shoes, they have to apply the topical, they're going to have the laser, you're going to do the debridement. One important thing about laser treatment for onychomycosis, if they've not had, if you look at the image on the right, if this nail has been detached from the nail bed for the last decade, you can get rid of the fungal nail infection, but you are not going to get the nail to bond down to the nail bed. It's just not been my experience. If you look over here 8 months out, you can see the nail looks better, but you're never going to have a nail that's going to bond down to that again. That's just the way it is. Post-op and pre-op protocol. So this is a really good time to talk about. So if you have patients who have complications, risk for complications, let's say they have Raynaud's, or they have had a wound, or they're smokers, or they've got other risk factors like diabetes, you can use a laser to do pre-op protocol. So a pre-op protocol for us would be you come in weekly for the 4 weeks before the surgery. Typically, patients going to be coming in to do consent or review the paperwork. So when they come in, we have them enroll in a laser protocol, and they get lasered once a week for 4 weeks up into the surgery. And that photobiostimulation gets their foot ready at a cellular level to have optimal healing. And it helps reduce pain significantly postoperatively. The post-op protocol, my surgery patients are coming in usually once a week for that, that post-op period. Those patients, when they come in, the post-operative protocol that I use is they come in, the MAs will take off the dressing, they set them up on the laser. We set the laser for pain and inflammation. That takes a short period of time, and then I'll come in, do whatever I need to do. If we need another dressing, we'll do that. And typical post-op protocol, 2 visits per week for 6 weeks. So the patients in my practice, they purchase this laser protocol from us, and we explain that it will reduce their risk of scar tissue, it'll reduce the pain, it'll help the healing. I've got a couple cases next week that are patients who've got wounds that we're going to go do some debridement on percutaneously, and one patient we're going to remove an old stump that keeps breaking down. But in those patients who have wounds, again, those are patients who would ideally benefit from this, because we're going to get them in the best cellular place with the photobiostimulation to get them in where they need to be to heal. Contraindication for laser is basically the basic. So we have pregnancy, because no one's ever done a clinical trial on pregnant patients, although I wouldn't have any, if it was a family member, but for your sake, if you do have somebody, much like if they were pregnant, you wouldn't take an x-ray just because you want to be careful. You don't want to expose the eye to any of the lasers. So typically you have protective eyewear that you'll wear and your MAs will wear, the patient will wear during their treatment. That's very important, because obviously, particularly the more powerful class 4 lasers, if that laser was to get in the eye, could damage the eye. You wouldn't want to do laser over an active cancer. So when it comes to warts, if you're not sure it's a wart, always biopsy. But if you've got a clean biopsy and you're looking for a treatment, we can use lasers for warts. But if you have anything that's suspicious that you might think is a tumor, don't use a laser. For example, recently I saw a patient who had been told she had a plantar fibroma. We did ultrasound, which the prior doctors had not. We could tell that it was not a plantar fibroma. She had received a few years of cortisone injections. It turned out to be or sarcoma. So again, always do good diagnostic workup with your patients. Again, lastly, over hemorrhage, if you've got an acute trauma with either a hematoma or active bleeding, as we said, lasers increase blood flow, so you don't necessarily want to do laser for those patients. Now, as I mentioned earlier, there are states where you don't have any codes, or you wouldn't be able to bill for any coding for laser. These are the typical codes. These are basically physical therapy codes. Most of these codes require the patient be treated by the provider. That means I have to be in the room doing the treatment. Some states allow the MA or the nurses do it, the amount of time that you're doing it to build these codes. For the better part of 16 years of my laser, we never had any of these codes, so we were using as a cash model for patients, much the same way we would ask for money for orthotics. We would present laser as a treatment option. We would give a handout to the patient explaining what it was. I would typically give them their first treatment for free, and when they were done with that treatment, ask them if they'd like to enroll. When they would go up front, they would enroll in the laser treatment protocol. There are lasers in my practice that have their own schedule. So we have the provider schedule. Each laser has its own schedule, particularly when it comes to onychomycosis. I do want to make sure, because we have multiple providers, that the laser has appropriate time. If I'm seeing somebody for the first visit and I'm going to incorporate laser into the protocol, I can ask, since we have more than one laser, if that laser is available. Come in. I think a good practice management tool and to promote your practice is to give the laser the first treatment for free, and see how the patient likes it, how they felt, if they noticed an impact, explain to them, give them literature, and the patients usually respond quite well to that. One of the things that I do, and I've always done for laser, if it's out of pocket, if I explain to the patient, you're going to buy 6 visits. At the end of the 6 visits, if you've done well and you've done everything I asked you to do and you're happy, great. If you haven't done well, but you've done all the things I asked you to do, you ordered the orthotics, you did the K-taping for heel pain, you did everything I asked you to, and you didn't feel better, I'll give you 6 more visits on me. And the patient said, "Oh, that's very nice." I said, "And at the end of those 6 visits, if you're still not better and you're unhappy with what I provided, I'll give you your money back." And universally, that makes it very easy for the patients to understand that I stand behind my word and about the technology, and if you're not better. The fungal nail patients are a little different. So what I do with fungal nail patients is when we sign patients up for the fungal laser, is I explain to them we're going to take a fungal culture before we start, so we have documentation of what we're doing. We'll take some pictures. You'll be receiving the treatments based on the treatment protocol. It will take 6 to 12 months for that nail to grow out. At the end of the 12-month follow-up, if you're not happy with the outcome of the fungal laser and you did the shoe treatment, you did the topical, you did everything I asked you to do, I will reculture, and if you have a fungal infection, I will repeat the fungal nail laser at no charge for you. If it comes back negative, then we could talk about it, and maybe we wouldn't give another treatment for free. But universally nowadays, with the internet and with people posting reviews about your practice, laser is a wonderful way to boost your reviews because you're doing modern medicine, you're offering treatments that don't have side effects, and you're building your reputation. But you can also be very careful to under promise and over deliver on the the use of laser for your patients, and making sure that you don't end up in the negative review business. So those are some pearls about how we deal with laser in our practice. Again, what I do is typically talk to the patients on the first visit about what their treatment options are. I will, for each condition, offer the laser as part of the healing cascade about how we can fit laser in. And I will typically say, instead of writing you for a drug or giving you a shot, I'd like to introduce you to laser. I would like to have you understand what laser is. Would you like to try it today? Sure, they usually say, and we bring the laser in, and we do a first treatment for them at no charge. That's a very good way of introducing to the patient to it. I think it's important that you do it that way. If you just stick a patient in the room with a laser without the explanation, without the personal touch, it doesn't go over as well. And I think you should make lasers as part of your marketing. Many of you have a good social media presence. We make laser part of our website for our group practice. I've got a lecture on our group website about me being interviewed about cold laser and how we incorporate that into our protocol. So that's part of my website. In addition, one of the things you can do to boost your practice, particularly now during COVID, there are a lot of practices around the country that were affected negatively from a patient volume perspective. What I did in the fall when we were trying to get back on our feet and get those patient volumes up is I went and visited the primary care doctors that are in my group, and I would have lunch with them. I would bring the laser with me. I would bring some laser handout. I would talk to the nurses. I would talk to the MAs, and I would talk to the primary care doctors about laser. Most of them had no idea that we even did it, even though they're in my group. They had no idea what it was. Offered to treat them with a laser, and I got a lot of referrals out of that particular visit in the fall. So I would typically do a campaign of laser to primary care. One of the things that I've done in the past is taken the fungal laser treatment mode to the really nice spas. We've got nice spas in our area that do nail care for patients. They do pedicures. They have medical pedicurists. They do all types of things. So I've done a wine and cheese kind of thing at the spas to get the spa owner and the technicians aware of what lasers is. Give them a business card with a little explanation of laser onychomycosis. That's been very helpful. And each quarter we do a different presentation, but lasers is a really nice way to improve your patient outcomes, as well as improve your reputation, improve your reach. The other thing you could do with the lasers is go to your local running shoe store. talk to the runners and the triathletes. I have a huge triathlete following in my practice. One of the reasons I do is because we work with a lot of them. We keep them running. We use a lot of K-tape. We use orthotics. We use great shoe gear. So talking to different groups that would benefit from lasers. If you work with dancers or gymnasts, being able, all these athletes are looking to get back to training and competing as quickly as possible with minimal side effects. So again, the laser is a great tool in your toolbox, but nobody knows it unless you go tell them about it. You know, you may have it on your website, but get out, talk to runners clubs, talk to running shoe stores, talk to athletes clubs, you know, anybody that you can get in front of, and bring your laser with you. Show them how it works, treat them. It's a really nice way to open up and build your practice while you're modernizing what you're doing to help them. So we're coming up against 15 minutes left, and we've got time for questions. So I wanted to put up my email address and my office number. If you feel free to email me or call me, so that I can answer your questions if you've got specific cases or questions about lasers. I've got lots of experience. I work with lots of different laser companies, so I'm very happy to help in any way that I could.
So the first question is, how effective is laser for fungal nails? Studies I have seen were not very promising.
All right, so that's a great question. So the studies, there are two studies to think of. The Middleton study showed an 89% cure rate with the laser. They were using the U.S. study that was done about 85%. I think in my practice that the superficial distal onychomycosis, great results. The patient that's had fungal nail with the onychogryphotic nail, where the nail is separated from the nail bed, I would say that the fungal treatment will make the nail more manageable. It'll eradicate the fungal infection, but you're going to still have nail pathology. So I think, so for mild to moderate onychomycosis, I would say the results that I see in my practice with 2 years are probably 85 to 90% successful. The patients that have the severe onychomycosis with the onychogryphosis and the nail separating from the nail bed, the nail will be much easier to manage, much easier to cut, but you're never going to get a normal looking nail. And I think that that's important to let the patient know. I also think it's important for the moderate patients to let them know it's going to take 8 to 12 months for the nail to grow out.
And going right along with that, Chris, we have another question here that wants to know what success rates that you quote for onychomycosis for either a mild case or severe case, what you quote to your patients.
Yeah, I think what I do is I tell the patients that the published success rates are in that 80 to 85% range, and that my experience has been in the same. With a mild to moderate, 80 to 85% success rates. You can improve your success by using the ultraviolet shoe sterilizer dryer combination, as well as you come in for periodic debridements, and I use a topical tea tree oil.
Okay. Who in your office is allowed to administer the treatments, which I think you talked about in your lecture, and is the DBM direct supervision required?
Yes. So if you're it depends on the state, and obviously please check with your states for your own individual state requirements. But in the state that I live in, if you're going to bill for it, particularly if you're using the codes that we went over, it has to be the physician of administering the treatment. There are two different types of laser applications. The lower lasers, the class 2 and Bs, a lot of them are set up to be unattended, meaning that you kind of bring the laser in, you position it, you turn it on. Technically, you could leave. All right, but if you're billing for a code that's attended, you need to be in the room. If you're using a class 4 laser, those are typically not those are attended, meaning that the provider is administering the practice. I know that I have colleagues in other parts of the country that have class 4 lasers that train their MAs to do it. I have no issue with that whatsoever, but individually, you should check with your own states, particularly if you're going to be billing for it. But if you've got well-trained MAs and your state allows you to do that, I would wholeheartedly encourage you to do that.
Well, thank you, Dr. Bromley. And the next question we have is, what is the duration of the increased cellular stimulation, benefit, pain relief, etc.?
We'll say that again from the top, slower.
What is the duration of the increased cellular stimulation, / benefit / pain relief?
Okay, so there's two types of pain that I'm thinking about. So the first patient are the patients who have the painful diabetic peripheral neuropathy. Those are, that 20% of patients that have that burning neuropathy. Typically, those patients in my practice are typically taking some sort of B supplementation. They may be or not be using a topical compound, but those patients will typically come in twice a week for 6 weeks, and that provides them enough relief because of the nitric oxide release that they're usually good for 6 months. So those patients will be coming in, periodically, but usually that painful diabetic neuropathy patients are good for the relief, will good for 6 months. Each treatment, if you think about there's 6 treatments, each treatment you'll get more and more relief. For the post-op pain patient, those patients are, when they come in twice a week, they're pretty good. I mean, most of my patients will say things like, this wasn't so bad. I didn't even need to take a Tylenol. I feel really good. And, we've been able to reduce the inflammation and swelling. And I think that a lot of the post-op pain has to do with the swelling. So I think being able to kind of control that works well. We typically wait patients will about 5 days post-operatively to start that, just as a pearl, because obviously we've got some bleeding there that we don't want to jump on too quickly. But after 5 days, we start the post-op protocol. Next question.
Thank you very much. Next question, Dr. Bromley, is would you ever combine an oral antifungals with laser treatment?
You could, but the whole purpose of using a laser is to provide them a non-toxic, with no side effects. I don't think it's a bad thing, but I haven't needed to. I have a very holistic practice, and I have a lot of patients who come here because of that. So most of my patients would probably be opposed to taking something by mouth. I do know, and I have practitioners that I'm friends with that they've been using an oral antifungal like terbinafine, and they pulse it, like 1 week, and then nothing for a month, and then 1 week. I think that in your hands, and if your patient population is open to doing that, and you feel comfortable, that's great. As I said, I will always use the shoe sterilizer. I learned that from Kerry Zhang when he was doing the U.S. study, when he and I were working together. And I always use a topical just because I want them to, get something to help with the healing. And I use tea tree oil. Next question.
The next question, Dr. Bromley, is post-onychomycotic treatment, will patients still need to perform shoe treatments, etc.?
A good question. So it really depends on what I typically tell patients is to treat all their shoes, once a week, one shoe once a week with overnight while they're during the treatment. And then I recommend, since they bought the device, is if they have most people have a couple pairs of shoes that they wear a lot, and they don't realize that there's a lot of moisture in shoes. And I do think it's a good idea to treat your shoes like once a month after you completed the treatment, to make sure that you're getting rid of the ultraviolet is good at decreasing foot odor, decreasing the risk of recurrent onychomycosis as a result of fungal contamination. So usually the answer is once a week during the treatment, and once a month for 6 months or so afterwards, to prevent recurrence.
Thank you very much. So now that we're past the CME portion of the lecture, we have a number of questions that ask what brand of laser you use. And one specifically would like to know, what brand of laser do you use on your neck? Because he too has neck pain.
Oh, okay. So I have a couple of Class 2B lasers from Merconia, the FX35, and we have a Lunula that's here. And then the Berman lasers are the lasers that we use that are the Class 4 lasers here in the practice. I've used, I had Class 2 for a number of years before I had Class 4. So I've used them all. At home, I have one of the portable units at home that pretty much travels with me, and I pre-COVID did quite a bit of traveling, and so I have that. Here at the office, I've been using the Class 4, the Berman laser, quite successfully. Recently, I slipped and fell before I went in the operating room, and I have some spinal stenosis, and I had some pretty bad SI pain. So the Berman laser, I would come in a little bit early in the morning, step into the treatment room and go ahead and treat myself with that Class 4 laser, which is, there's some warmth associated with a Class 4 laser. So it felt really good to do that. And I think that was one of the reasons why that and massage, that my recent fall, I was pretty much back to normal within about 4 weeks.
Okay, well, thank you very much, Dr. Bromley. And I think we have time for maybe one or two more. How much time does it take to treat bilateral neuropathy? And does higher power lasers work better?
So a bilateral neuropathy patient would typically take, if you're using a Class 2 laser that's unattended, meaning that you just position it over, like the Orconia, it would take about 10 minutes per extremity. If you're using a Berman laser, a Class 4 laser, about the same. You'd spend about 10 minutes on one knee down to the foot, and then about 10 minutes on the other. Again, we're measuring the amount of joules per the extremity, about 10 joules per extremity. So again, about 20-minute visit. But if you're in an area where you're allowed to use MAs to do the treatment, I would encourage you to make that part of your protocol for your neuropathy patients.
And we have a number of billing questions, which I think you covered a lot of the insurance at the end of your talk. But a few people wanted to know, what were some ballpark figures that you might charge patients for some of the procedures that are not covered by insurance?
Oh, that's a great question. So what I typically do is we have packages, laser packages, and it depends on your area. I live in the Hudson Valley of New York, about an hour north of New York City. It's not a particularly wealthy area. So what I found is that we charge about $75 a treatment, and they can buy that as a package of 6. Some patients want to pay per treatment. I really think that getting the patients to invest in the 6 is important, because if you sell them one and it doesn't work, they're just going to say bad things. So I explained to the patient that it's going to take about 1 treatment per decade to see and really notice some improvement. So I'm 5 decades old. It would take at least 5 treatments for me to get better. So if you sell the patient one visit, one laser for $75, and they don't see a difference, they're not coming back for the second or third. So get the patient to invest in the 6 visits. I charge $50 per. We package that together, and they pay for that. They can use care credit. They can use a credit card. And if at the end of 6 visits you're not better, I'll give you 6 on me. If you did everything else I want you to do. And if you're still miserable after 12, I'll give you your money back. And the number of times that I've ever had to do that in my practice is 0. Because we take a lot of time educating patients. We do all the things that you do, taping, orthotics, activity modification, strategy, all the stuff that goes into it. But I really think that my advice to you is feel free. I mean, I know folks around the country can charge $100 a visit. I know there are places in New York City that charge $150 a visit. If you live in an area where the economics of your area, you can get up to $150 a visit, go ahead and charge it. I tell the patients when they come in, if they're seeing the laser and it's unattended, they're not paying an office visit or a copay. If it's an attended that I have to do, you're going to pay for the laser and you're going to pay for the visit, and with me. Next question.
Okay, well, I think that's about all we have time for, Dr. Bromley. Thank you for sharing your knowledge with us again. Another excellent lecture, and we look forward to seeing you again in the near future.
All right. Thank you, Steve. Appreciate it.